you haven't done anything, you know? When you got somebody who's working two shifts and they're getting off at, 11:30 at night, and they're on their way home and they're hungry. They haven't had a chance to have dinner because, they work two jobs, and they walk past the corner store, which is open 24 hours a day, 7 days a week. But what they have in there is high fat, high salt, low nutritious foods. They're going to pig out because they're hungry. And the dietitian be damned. They love the dietitian, but that consult didn't do you any good. And of course, their weight problem didn't get resolved. Their diabetes didn't get resolved. Their high blood pressure didn't get resolved because of all the salt they were eating. And it's not that they didn't, as we say, know better, but the answer was their social condition was such that they had to get to bed, they had to get up the next morning, and going to work to feed their family was their top priority. And they cut down a little bit because the dietitian said, don't eat too much of these chips, don't eat so much of that salt. So they cut it down, but it wasn't good enough. And when I was a city health commissioner here in DC, and I remember that in the poorest part of town, for most of the time that I was in the DC area, there was not a full service grocery store anywhere in that community.
Right. That's true in Philadelphia, the same thing.
To street vendors in New York, and the health department intervened and said, well, what we really want you to do is only license people that are selling fresh fruits and vegetables, and only in communities where there's a food desert for fresh fruits and vegetables. And a big fight ensued, because these are very valuable licenses. The health department prevailed, and they did it. And so you put up these vendors. They were able to actually set up a business. They would go down to farmers markets around the city, and they would buy fresh fruits and vegetables. They would carry those fresh fruits and vegetables into in communities where there was really a dearth of fresh fruits and vegetables. And a couple of things were demonstrated. And this, by the way, this project was actually evaluated for efficacy and outcomes. And they proved two things. Number one, lower income individuals will buy and consume fresh fruits and vegetables. But the secret is that they have to be fresh and they have to be affordable. And it turns out that many of those vendors were able to sustain that as a business model in order to do that. I don't know if the project is still going on in New York. This was several years ago when I was living in New York on a sabbatical. But I got to tell you, that kind of thing is important. In DC, the challenge has been, how do you keep that grocery store in the lower income part of town? And the answer is, how we always keep businesses in communities? By tax subsidies and incentives. So there's a national and business incentive to subsidize these and support those businesses in some way. And, we do this for rich businesses all the time. Rich people get richer because we do this. We use our taxpayer dollars to incentivize them. Why not do that in communities where we want to improve the health of those communities? Because there actually is an economic savings to society when we do that.
Signs of a society is how well it does with its maternal and child health and its birth and things like that. So I know, Dr. Benjamin, that you were involved with those programs. Tell me a little bit about the issue of maternal and child health.
Yeah, the challenge we have is that we have tragically far too many kids who don't survive their first year of life. And we have way too many women who are getting pregnant for whom that pregnancy is high risk for a variety of reasons. It's high risk because they are not healthy. It's high risk because they smoke or they are using substances, illegal substances. It's high risk because they are having multiple babies. For a variety of reasons. Some of it is because they've been struggling to get pregnant and they're under the care of a physician. who is, using medications to help them get pregnant. So when you do that, you have more babies, smaller babies, and then on top of that, they're not really being managed properly as a high-risk pregnancy. Around many people that are living in the inner city is just such a challenge. Many of our friends and neighbors are living very stressful lives, and stress because of income inequality, because of racism, because of their housing condition, because of issues around income, quite frankly, impacts that pregnancy in negative ways. And so we've really got to work harder to address those social conditions that at the end of the day create enormous stress in our communities, enormous stress for women who are pregnant. And then we need to make sure that we as clinicians listen to our patients, because far too often the clinicians that are taking care of patients aren't listening to them when they tell them that something's wrong with their body, that they're having challenges. And we need to sit back, open our ears, pay a lot more attention to that, because we have several, high visibility people that have had, significant postpartum challenges or pregnancy challenges. And when you talk to them, they'll tell you that their docs weren't listening to them.
One of the things that I actually had a big argument is that, as you know, the first trimester is where most of the development of the baby takes place. The neurological system, all of that, that's all developed in the first 3 months. And one of the things that I noticed was that a large percentage of people don't even know that they are pregnant at that point. So it's very hard to get any type of intervention or vitamins or, any of that stuff. They don't even know they're pregnant. They don't know it until the trimester is done. So therefore, a lot of the damage is already done. That's going to lead to your low birth weight before you even get involved in the system. Many of the programs, they're maternal programs, but they don't involve the young men. If it's a nutrition, if it's a class, whatever, it doesn't even really, I think, seek to bring them together. Would you agree with my assessment in terms of these issues?
I absolutely agree with you. There's no question about that. We need to, put back health education in our schools. We need to keep our head, take our head out of the sand around reproductive education, sexuality in schools. There are these fears that somehow if we teach that, kids will find out about it. They're going to find out about it in the wrong ways. Yeah, kids are not stupid, and they're living in an ecosystem where they're getting that information, in very much an unstructured way. And so, to the extent that we can do some level setting in an educational setting where it's neutral, where they're getting information from trusted messengers, is very important, and it has to be for both men and women, regardless also of how they identify from a gender perspective. So there's a lot of misunderstanding, lack of understanding around a whole range of reproductive health issues for people, how you get sexually transmitted diseases. There are people who don't think you can get it if you have intercourse in a certain way, not really understanding anything about disease transmission. But I got to tell you, the other thing that we have is, again, I remember, and I'm sure you saw this in your health department, that when we went out and we talked to these young people, these are kids that are in 6th, 7th, 8th grade, and we would sit around and talk to them about issues in their lives and try to talk to them about early not smoking, not having sex before you were ready, those kinds of things. They would look us straight in the face and say, in my community, I don't think I'm going to live to be grown. They don't see their hopelessness, hopelessness and helplessness in their community. So basically, in many ways, they see them living their lives as you might if you had a terminal disease. That's certainly for some of our kids that are in really, really challenged communities. And for the kids that do get out, they need to be really celebrated and supported much more than we do.
Yes.
Because what also happens is when they get to college, that they're not often surrounded with the social supports that they need, so they actually finish. And then there's a second fall off of many of these kids coming from underserved communities, or were, going to college. They're first generation attending to college. There are three things that people should do for colon cancer. First of all, they should get routine physical examination. That includes a digital rectal exam. So you put your finger in someone's rectum, because a lot of, particularly the lower level cancers, can be actually felt with the finger. You'll feel a mass early on. Secondly, checking your stool for blood. We call it a hemocult test. That's where you put a little stool on a card. Often you'll send it into your doctor, and the doctor puts a fluid on it. And if it looks like there's blood in your stool, they will then do a what they call a colonoscopy, where they stick a tube up and look around to see if there's cancer or a polyp there, or something that's bleeding, to explain the blood. And increasingly, colonoscopy is becoming in many cases, a standard of care at a certain age to start screening for cancer. But it's expensive. It does require you to have what we call conscious sedation. It does require it to be done at a facility, not necessarily a hospital, but sometimes an outpatient ambulatory center. But at the very least, people ought to do the hemocult test, and then consult with their doctor.
Can you tell me a little bit about that issue? That's a very big issue in terms of public health, because we have these new tests now.
Yeah, what I know about it is that it's for people who are average risk. It's a reasonable screening test. But if you have a family history of colon cancer, if you're having rectal bleeding, if you've done any of the other tests, if you have a history of polyps, then it's probably not the right test for you. You really need to see your doctor and then ultimately see a gastroenterologist. Most people start talking about doing the colonoscopy somewhere between age 45 and 50 for people who are at average risk. But Cologuard is a test. It's out being marketed, and you do it. I think you mail it in, and then they tell you whether or not it's positive or not. But it's a screening test.
Right.
And it still may mean that regardless, depending on the results,
have the colonoscopy if it comes back positive. I agree.
Definitely, yeah.
Or estrogen, progesterone, and HER1. Can you tell me a little bit about this particular cancer, breast cancer in women?
Yeah, you're right. That breast cancer in women, particularly women of color, occurs. When it occurs, it can occur much younger, and it tends to, like prostate cancer in men, tends to be more aggressive. So the Preventive Health Services Task Force, which is a national task force that makes recommendations, usually starts saying that women ought to start getting a mammogram something about the age of 40 and going till about the age of 74, 75, somewhere in there. I think the challenge that you have is that one of the reasons that it's really good to know is because if you identify these cancers early, we can now do a biopsy on that cancer, show that it, on the lump, show that it's cancerous, and then they can do some genetic testing on that cancer, and then they can give targeted therapies, which would be much more effective. When I was a resident, we would basically give women chemotherapy under various protocols based on understanding in science and research that's been done, but it was still very crude. And you'd give someone 3 or 4 drugs, and then you would we'd make them really sick. We drop their white blood counts. They get infected. Then they recover, and then we do it again. And then if they failed that protocol, we move them to another protocol. And all this was based on the best science that we knew at the time, but it was pretty gross. It was basically on gross tissue type. Now what we're doing is actually looking at the genetic structure of that cancer and targeting drugs that disrupt the growth of that particular cell type. So they're much, much more effective in terms of treating women. The women get less sick because you're able to optimize the dose of therapeutics that you're giving them, the anti-cancer medications. And so we've learned a lot about treating cancers. And we also know that because of these various understandings of the genetic types, we now know that they can run in families. So that if a family member has had cancer, there's a greater likelihood that you might also have that same type of cancer should you occur that cancer in the future. And that helps with knowledge. So family history is important. The testing is important. The genetic testing is important, and targeted therapy. And then I might add, again, going to a cancer treatment center that has done a lot of these things.
Yes. It's been a very interesting conversation, Doctor, and I hope that in the future I can have you back and we can go into some more of these topics. I think this is going to be very informative information to our listeners. So thank you very much for participating on the Insightful Journal. And don't forget, if you like what you've heard, please subscribe and press that like button so that we can bring more programs like this. Thank you so much. Goodbye for now.
Thank you.